A very good morning to all. I am Dr. Anshika Dengre and I will be presenting this CGR on behalf of the Department of Anesthesia on the perioperative care of pediatric surgical patients. Our experience since the beginning of the Pediatric Anesthesia Fellowship Program. Over the last 6 months, we've managed a total of approximately 1,200 pediatric patients. Of these, 540 cases were conducted under non-operating room anesthesia, which included MRI, CT, DSA, nephrology, endoscopy, and radiotherapy. 61 emergency cases and 367 elective cases were done in pediatric surgery, 102 pediatric urology cases being done in the main OT complex, 85 cases in plastic surgery, and 46 pediatric patients underwent robotic surgery under both pediatric urology and pediatric surgery. Approximately 1/3 of our patients were below the age of 1 year as shown in the pie chart. The type of cases that were managed in the operating room were predominantly under pediatric surgery and pediatric urology and included open and laparoscopic abdominal surgical procedures, cystoscopic procedures, surgeries of the head, neck, and airway, and spinal anomalies like meningomyelocele. We have an ICU on the first floor of PMSSY, and I will now be discussing our ICU trends and outcomes. Since June, we've admitted a total of 482 pediatric patients. Of these, 469 were transferred in from the OT for postoperative care, and 13 had been transferred in from the ward. This chart summarizes the age profile of our ICU patients. Most of our ICU admissions were short stays of less than 24 hours. 37 children needed ICU care beyond 24 hours, which were largely postoperative. Around 28% of the admitted patients required overnight ICU stay. Indications for overnight stay predominantly included postoperative monitoring and care, need for oxygen support, or requirement for invasive or non-invasive ventilation along with vasopressor support. We would now like to share some insights from behind the scenes, aspects of perioperative care that often go unnoticed but are crucial in keeping our pediatric surgical patients safe. This is the case of a neonate with a giant omphalocele. Usually, the general dictum in large omphaloceles is a two-staged repair to avoid postoperative respiratory complications and abdominal compartment syndrome. But with physiological monitoring and non-invasive ventilatory strategies, we could achieve this repair in a single stage. We want to share that experience through this case. This was a 7-day-old baby with a defect size measuring 6 × 5 centimeters, containing solid viscera such as the liver and spleen. This was a term baby referred to SGPGIMS for omphalocele repair and posted for the same on day 7 of life. As previously mentioned, the defect size was 6 × 5 centimeters, which was a large defect containing solid viscera. Omphaloceles are midline abdominal wall defects containing herniated viscera covered by a membrane. The incidence is 1.24 per 10,000 live births. Out of this, only 37% have solid viscera. These children are at high risk due to pulmonary hypoplasia and small abdominal cavity, causing abdominal compartment syndrome. Literature-wise, When we reduce these large omphalocele, it results in raised intra-abdominal pressure. Rapid rise can cause abdominal compartment syndrome, leading to bowel ischemia and post-operative respiratory complications. Thermoregulation is also a concern due to the large exposed sac. Understanding and preventing abdominal compartment syndrome. When reducing omphalocele, intraoperative parameters such as peak airway pressures can warn regarding impending abdominal compartment syndrome. Decreased urine output, hypotension, or desaturation are warning signs and dictate us to stop reducing further. I would now like to narrate how we manage this omphalocele in a single staged repair. To begin with, the child was intubated and ventilated with a baseline peak inspiratory pressure of 18. An orogastric tube was inserted for continuous gastric decompression. Gradual reduction of contents and constant communication, along with monitoring and sharing of peak airway pressures trends in real time, was done as reduction advanced. It was planned to stop reduction when peak inspiratory pressures rose significantly. But it was not so in our case. Peak inspiratory pressures rose to 22 after complete closure, which was acceptable. Stable EtCO2, oxygenation, and hemodynamics ensured that the baby was extubated post-surgery. Parameters monitored postoperatively included abdominal girth, lactate levels, and urine output, which remained within normal range. Derangements in the above would have helped in early recognition of rising intra-abdominal pressures or poor perfusion. But there was no evidence of abdominal compartment syndrome postoperatively. This child was extubated but needed nasal CPAP due to limited thoracic expansion and basal atelectasis from the defect, which was a postoperative concern. Nasal CPAP kept the alveoli recruited, provided gentle distending pressure without stressing suture lines, and allowed spontaneous breathing while maintaining oxygenation, while also reducing the work of breathing and need for intubation. Thus, primary closure and early extubation was safely achieved in spite of a giant omphalocele. Physiology-guided decision-making proved more reliable than the defect size alone. Close postoperative monitoring and multidisciplinary coordination between the anesthesiologist and the pediatric surgeon enabled early detection of respiratory or abdominal compartment concerns. Thus, a favorable outcome was achieved in spite of initial apprehension. Our next case is that of a child having multiple congenital anomalies who was operated quite a number of times. We had an emergence crisis, which was tackled with the help of laryngeal ultrasonography. Let me start with a short background summary. He was a 3-year-old child with repaired tracheoesophageal fistula, persistent gastroesophageal reflux disease, and multiple musculoskeletal anomalies. He was a 34-week preterm infant presenting with high anorectal malformation, a type C tracheoesophageal fistula, a 3 mm subaortic ventricular septal defect, right clubfoot, left facial nerve palsy, and torticollis, along with scoliosis, microtia, and sensory neural hearing loss. He underwent primary repair of tracheoesophageal fistula and sigmoid colostomy on day 1 of life. He was then admitted to SGPGI with respiratory distress following surgical correction of the tracheoesophageal fistula and anorectal malformation. He was managed in the NICU on nasal CPAP, experiencing a few episodes of desaturation due to regurgitation of feed. Hence, he was investigated for the same, and severe persistent gastroesophageal reflux disease were documented. For this, the mother was advised to nurse the infant in a propped up posture. Despite taking proton pump inhibitors and prokinetic agents, the infant still experienced multiple episodes of respiratory distress due to regurgitation of feeds. He underwent posterior sagittal anorectoplasty and surgery to maintain continuity of the bowel as a final correction of his congenital anorectal malformation at a hospital. Both these 2 to 3 hour surgeries went uneventful. As a sequelae of tracheoesophageal fistula repair, he had an esophageal stricture for which esophageal dilatation was done at the age of 2 years. Now, he came at 3 years of age for the present case of urethroplasty and Cody correction. Based on this, the child was considered high risk for perioperative respiratory complications due to severe gastroesophageal reflux disease, recurrent aspiration pneumonia, and respiratory distress, along with an increased risk of hyperreactive airway after tracheoesophageal fistula repair. We also anticipated a difficult airway in view of left facial asymmetry, torticollis, short neck, and scoliosis. The child also had a specially designed chair that he used to even sleep in due to his inability to lie supine, adding to our difficult airway. So, on the day of surgery, the child was pre-medicated for separation anxiety, nebulized in view of his hyperreactive airway, and wheeled in the operating room on a propped up ICU bed, taking care of his gastroesophageal reflux disease. After induction with fentanyl, propofol, and rocuronium, 3 attempts of laryngoscopy were done, which failed viewing of vocal cords. As per the difficult airway algorithm, our next step is to secure the airway with a supraglottic airway device. These are not normally used in GERD, but now newer generations of supraglottic airway devices have improved seals and separate gastric ports, facilitating suction and aspiration. Due to airway manipulation, in spite of preoperative nebulization, the patient had bilateral wheeze, which was managed with hydrocortisone and salbutamol puffs. Gradual improvement in ventilation was observed. Once improvement was noticed, we continued with the surgery. 3 hours of the surgery went uneventful. Post-procedure, the child was re-nebulized, reversed of muscle relaxant, washed for adequate efforts, after which we removed the airway device. But after removal of the airway device, the child had chest retractions, decreased air entry, desaturation, and we were now unable to mask ventilate the child, which was previously possible. So the LMA was reinserted. But this time we were unable to ventilate even via the LMA, which was also previously possible. So we did a video laryngoscopy, which revealed significant glottic edema. A small-sized endotracheal tube placement was managed with great difficulty, and we were finally able to ventilate the child. Due to inadequate ventilation, he had retained carbon dioxide and now had respiratory acidosis. We nebulized the child with adrenaline and levosalbutamol for glottic edema and hyperreactive airway and performed a laryngeal ultrasound. Now, last time we had removed the LMA and landed up in trouble due to the glottic edema and were able to intubate the child with great difficulty. So, this time we were wiser and did an airway ultrasound. Laryngeal ultrasonography is a useful non-invasive tool for the evaluation of vocal cords and laryngeal morphology in intubated patients. So, after nebulization with adrenaline, we did the ultrasound, which showed resolution of cord edema. So, we extubated the patient. The child had no post-extubation stridor and was shifted to the postoperative area on nasal prongs. After this, the child was kept in post-op for observation. He required supplemental oxygen via nasal prongs for around 40 hours. He was observed on room air for another 8 hours prior to shifting to ward. Thus, the air column width, measured by the ultrasound, may potentially identify patients at risk for post-extubation stridor in whom caution should be exercised after cuff deflation and extubation. Our institute is a referral center for tracheoesophageal fistula, and we want to highlight a problem in children after tracheoesophageal fistula repair who are coming for subsequent anesthetic and surgical interventions requiring endotracheal intubation, like in our case. He was a 2-year-old child posted for nephrectomy. He had a type C tracheoesophageal fistula, which is the commonest type. At 1.5 years of life, he visited the hospital with complaints of abdominal pain and distension. He was diagnosed of a kidney mass and posted for resection of the same. In all post-TEF repair cases, we evaluate for history of noisy breathing, recurrent respiratory infections, wheezing, coughing, or gastroesophageal reflux. Presence of any of these hint at persisting long-term post-TEF repair complications or even a persistent tracheoesophageal fistula. But this child was playful with no such history. General physical examination and systemic examination were normal, and blood investigations were within normal range. To add to the clinical interpretation, a CECT chest performed also showed no evidence of esophageal stenosis or persistent tracheoesophageal fistula or outpouching. So, on the day of surgery, the child was pre-medicated for separation anxiety, induced, bag and mask ventilation was easy, laryngoscopy performed, and intubated. But on auscultation of lung fields, to our distress, there was no air entry, no chest rise was observed, and no EtCO2 was shown on the monitor. We were unable to ventilate the child. We checked the circuit, ruled out kinking of the tube, rechecked the position of the endotracheal tube, suctioned the endotracheal tube for secretions, gave salbutamol puffs suspecting bronchospasm, but was still unable to ventilate the patients. But during these attempts at troubleshooting, the child saturation started to fall. Incidentally, neck extension during repeat laryngoscopy showed improved ventilation. Our saturation was now 100%. So, while maintaining neck extension, fiber optic bronchoscopy was performed and the diverticula was visualized. The tip of the endotracheal tube was sitting right on the diverticula. This diverticula had not been reported on CT, and the child had no previous respiratory complaints suggestive of the same. The endotracheal tube was then maneuvered under fiber optic guidance, trying to avoid the diverticula. This is fiber optic. We are just above the carina. At 3 o'clock, we are able to see the diverticula. Sorry. This is fiber optic. We are just above the carina. At 3 o'clock, we are able to see the diverticula. And we were able to intubate the trachea under fiber optic guidance into the true lumen of the trachea just above the diverticulum. The patient then underwent an uneventful intraoperative and postoperative course and was discharged on POD 7. Children with tracheoesophageal fistula often experience significant aerodigestive complications following repair, such as chronic cough, choking with feed, gastroesophageal reflux disease, asthma, allergic rhinitis, and recurrent respiratory infections. Acquired tracheal diverticulum consists of esophageal tissue that remains adhered to the trachea following surgical repair of esophageal atresia or tracheoesophageal fistula. As high as 33% incidence is reported post-TEF repair. Our patient was unique in the sense he did not have any symptoms. Since a very small percentage is asymptomatic, preoperative bronchoscopy is not routinely performed in post-TEF repair patients with no aerodigestive symptoms. In such cases, mask ventilation and endotracheal intubation is performed with ease, but as diverticulum can provide false tract, there is misplacement of the endotracheal tube into the diverticulum, causing difficulty in ventilation. The wall of the diverticulum is weaker than normal, with risk of diverticulum perforation after positive pressure ventilation, leading to mediastinal or subcutaneous emphysema. This has already been reported in existing literature. Tracheal diverticula are generally diagnosed via CT, but it could have been missed due to the dynamic collapse of the diverticulum during quiet breathing and pressure-dependent expansion during mechanical ventilation. Thus, in our case, we diagnosed it on bronchoscopy. We need to be wary of tracheal diverticula as a potential complication post-TEF repair. Therefore, we propose the primary method of securing airway to include fiber optic guidance whenever feasible. Our third case describes a novel approach to anesthetic management in a preterm infant posted for an open herniatomy. This was an 8-week-old baby at 38 weeks post-conceptional age posted for right open herniatomy. Like I said, he was a preterm baby delivered outside SGPGI and admitted to our ICU in view of respiratory distress and prematurity. He was discharged at 37 weeks post-conceptional age and posted for right open herniatomy at 44 weeks post-conceptional age. So what makes preterm special? Immature respiratory centers put preterm neonates at an increased risk of apnea, the incidence of which is inversely. Immature respiratory centers put preterm neonates at increased risk of apnea, the incidence of which is inversely related to the post-conceptional age. Reduced residual capacity and compliant chest wall leads to rapid desaturation during airway manipulation in this age group. Moreover, anesthetic implications of congenital cardiac anomalies make general anesthesia more challenging, like our preterm had an atrial septal defect. There is always a dilemma of choosing appropriate technique of GA versus RA in preterm neonates. since GA is associated with increased risk of respiratory complications and delayed recovery, and subarachnoid block alone has a limited duration of action, high failure rate, and may not cover long procedures due to high CSF turnover time, lasting only 30 to 60 minutes in neonates. So, while trying to balance the two, we came upon a novel approach to address this issue, combining caudal plus spinal in a single puncture. This is made possible with the use of ultrasound, which shows real time needle advancement with drug administration and increases accuracy. Now, traditionally, spinal is given at the lumbar level. However, this is difficult to perform in real time using ultrasound. So, when we use the technique shown in the image, we are able to see both the thecal sac as well as the caudal space. This is the thecal sac and this is the caudal space. This is our point of entry. In this, under ultrasound visualization, the drug will be injected into the dural sac, withdrawn, and the remaining drug administered into the caudal space based on the dosing required in the two blocks. Like I said, the sacrococcygeal ligament will be the point of entry. The needle will be advanced up to the thecal sac. Spinal drug will be injected, the needle withdrawn and injected into the caudal sac. This point of entry is relevant in the pediatric population since the thecal sac is lower and we can access the caudal space. So on the day of surgery, the infant was sedated and placed in the lateral decubitus position, all aseptic precautions maintained. And the dural sac and caudal space were visualized with the ultrasound. 120 minutes of the surgery was successfully completed under combined spinal caudal block. The child was kept under observation overnight and shifted to ward the next morning. Spinal anesthesia has previously been performed in neonates for inguinal surgeries with approximately 5.8% failure rate. Using real-time ultrasonography, we enter the thecal sac via the caudal space, which increases success rate. To conclude, regional anesthesia avoids airway manipulation, minimizes GA exposure, and maintains spontaneous respiration. Ultrasound guidance increases accuracy and safety along with success rate, making regional anesthesia via this technique a viable alternative to general anesthesia in a preterm. We have recently used this technique to administer anesthesia to another preterm at 47 weeks post-conceptional age. That is, we gave both spinal and caudal, and there was complete blockade lasting the surgical duration of 90 minutes. Robotic-assisted thoracoscopic surgeries are always a challenge in pediatric patients due to limited gadgetry available for achieving one-lung ventilation. I am going to describe techniques in two patients which made robotic-assisted thoracoscopic surgeries possible in small children. So while in adults, we have many gadgets to achieve lung separation, like a double lumen tube, a univent tube, and bronchial blockers. In pediatric population, due to the anatomy and size of the tracheobronchial tree, it is not always possible to insert a double lumen tube or use other advanced gadgets. The smallest bronchial blocker available commercially is 5 French. Since this is always inserted with bronchoscopy, the minimum size of the bronchoscope will be 2.8 mm. So this assembly can be utilized in children who are intubated with at least an endotracheal tube with an internal diameter of 5.5 millimeters. This is the experience of 4 cases, out of which I will be describing 2. So we are one of the few centers where robotic assisted thoracoscopic surgeries are being done. So we hereby present a case of a 3.5-year-old child with bronchopulmonary sequestration posted for lobectomy via robotic assisted thoracoscopic surgery, in which we were able to achieve 1 lung ventilation by placing the bronchial blocker in a modified way. So this was a term baby who was antenatally diagnosed with intralobar bronchopulmonary sequestration with a mediastinal cyst. He required NICU admission in view of respiratory distress and was discharged on day 10 of life. Between 4 months to 3 years, he was in continuous OPD follow-up 6 monthly with a yearly CT pulmonary angio. He was a known case of bronchial asthma and was on levosalbutamol and budesonide nebulization for the same. He was then posted for elective lobectomy via robotic assisted thoracoscopic surgery at 3.5 years of life. Vitals, general physical examination, blood investigations, and other systemic examinations were within normal limits. The echo showed a 4 millimeter OS AST. The CT pulmonary angiogram revealed air trapping in the posterior basal segment of the left lower lobe with the focal air-filled cystic area suggestive of a mucocele, secondary to segmental bronchial atresia. There was also a well-circumscribed air-filled lesion measuring 10 into 5 into 12 mm in the subcarinal region. It was decided to manage the subcarinal lesion conservatively with regular follow-up due to its small size, asymptomatic presentation, and inaccessibility by left thoracoscopy. The parents were counseled regarding the anesthetic procedure and 1 lung ventilation, and consent was taken. The perioperative plan was discussed with the surgical team, and a dry run of the complete airway planning was done prior to the procedure. Due to the age, weight, and airway anatomy limitations, a special assembly was designed. This included the endotracheal tube and the fiber optic bronchoscope with the bronchial blocker. This is our blocker, this is the bronchoscope, and this is our endotracheal tube. So normally during intraluminal insertion, the endotracheal tube is inserted, followed by the fiber optic bronchoscope, after which the bronchial blocker is inserted under fiber optic guidance. Ventilation is done via this port to avoid desaturation during this maneuvering. Now, the ratio between the outer diameter of the fiber optic bronchoscope and the inner diameter of the endotracheal tube should be less than 0.7 to allow ventilation during bronchoscopy. But with our airway equipment, it was 0.85. So, the assembly would physically fit inside the endotracheal tube, but no adequate ventilation would occur. Furthermore, maneuverability of our equipments will be hampered. Thus, we came with a combo approach wherein the entire assembly was preloaded onto the endotracheal tube. This was done to shorten the intubation time and minimize airway manipulation in an already asthmatic child. Let's take a closer look at our assembly with the fiber optic bronchoscope and the bronchial blocker preloaded into the tube. Like I said, by doing this modification, we could quickly insert the bronchial blocker into position. Since the fiber optic bronchoscope was of shorter length, we shortened the endotracheal tube so that the bronchoscope could reach up to the carina. This also solved the apprehension that the subcarinal cyst should not get ruptured because of the tip of the endotracheal tube, just in case it goes beyond the carina. This enhanced our procedural safety. So, on the day of surgery, after pre-medication, the patient was induced, ventilated for 3 minutes, and laryngoscopy done. The whole assembly, that is the endotracheal tube with the fiber optic bronchoscope placed within it, but just beyond its tip, was advanced past the vocal cords and further till the carina was visualized under ambuscope guidance. The arm blocker was then directed into the left mainstem bronchus and balloon placement confirmed by conventional auscultation method. 99 to 100% saturation was seen throughout the airway maneuvering. The child had stable hemodynamics and post-intubation EtCO2 remained within normal range. That is, there was no hypercarbia. Here, you can see the ARNT blocker in the left mainstem bronchus and the entire assembly from the outside. So this is an intraluminal method of placement of bronchial blocker. After insertion of the first robotic port by open technique, the left lung was completely collapsed with adequate intrathoracic space for manipulation of robotic instruments. The left lower lobectomy was completed uneventfully. After completion, the blocker balloon was deflated and the lungs manually ventilated to check for leaks. The left upper lobe was seen to re-expand after completion of the procedure. The trachea was then extubated. The child discharged from the post-anesthesia care unit on post-op day 3 and discharged from the hospital on post-op day 5. We recently published this technique. In our next case, the technique of achieving one lung ventilation was via extraluminal insertion of the bronchial blocker. This was an 18-month-old male child who was an antenatally diagnosed case of bronchogenic cyst. He had recurrent history of lower respiratory tract infections since birth. His last LRTI was 20 days prior to being posted for elective robotic-assisted bronchogenic cyst excision on 22nd November 2025. During pre-operative assessment, the child was playful and active. On auscultation, there was decreased air entry on left side. Other systemic examination and blood investigations were within normal limits. The chest X-ray depicted left-sided hyperinflation, right mediastinal shift, and a left mediastinal opacity. The HRCT thorax reported a peripherally enhancing large cystic lesion in the mediastinum, closely abutting the mid-esophagus medially and extending inferiorly into the subcarinal region, producing significant compression of the carina. The lesion closely abutted and markedly compressed the left mainstem bronchus, along with mild hyperinflation and hyperlucency of the left lung. Superiorly, the lesion was in close relation to the aortic arch, while posteriorly it lay adjacent to the descending thoracic aorta. Given the small airway size, age of the child, and lack of working space in the trachea for an endotracheal tube allowing maneuverability of both the bronchial blocker and bronchoscope, we opted for an extraluminal bronchial blocker insertion technique. After pre-medication, the child was induced, ventilated for 3 minutes, and laryngoscopy done. A 5 French bronchial blocker was inserted. The 4.5 millimeters internal diameter endotracheal tube was inserted and fixed at 14 centimeters, post which the bronchoscope was inserted. It was noted that the bronchial blocker was in the right bronchus. So it was manipulated and inserted into the left bronchus under ambuscope guidance and fixed at 17 centimeters. This could be due to the obliterated left bronchus. So external manipulation was done and bronchial blocker guided into the left bronchus. The balloon was then inflated with 2.5 ml of air. The blocker position was confirmed and the child placed in lateral decubitus position. In our case, fixation of the bronchial blocker was challenging since the margin of error was very less. The blocker was repeatedly getting dislodged with position change and had to be repositioned via ambuscope. After repositioning, both the lungs were deflated, the blocker inflated, and the other lung re-inflated. Thoracoscopy then revealed a collapsed left lung. The surgical duration was 90 minutes. A serratus anterior plain block was administered for postoperative pain, following which trachea was extubated. This is a video of the child on post-op day 1. He was discharged on post-op day 3. We are evolving with our minimally invasive thoracoscopic surgeries. Robotic-assisted thoracoscopic surgeries have always been challenging in pediatric patients. There are multiple limitations to robotic surgeries, such as inability to approach the patient due to the robot. We are also evolving with our lung separation techniques, however, with limited gadgetry. There are unique challenges and anesthetic implications to each case, requiring a tailor-made approach. Integrating anatomical knowledge, sizing, innovation, and modification of available equipment can help provide a safe approach to one lung ventilation in these patients. To conclude, the challenges in pediatric anesthesia stem from immature physiology, unpredictable airways, hemodynamic instability from minimal blood loss, and a narrow margin for error in drug dosing. In here, diverse high-risk pediatric cases showcased critical perioperative challenges. Individualized anesthetic planning and timely ICU support were key to management. Multidisciplinary communication, improved intra and postoperative stability, and ICU OT integration enabled early recognition of deterioration and smoother postoperative transitions. Thank you.